Okay, so for anyone doing shoulder surgery blocks, regional anesthesia,
Hmm.
the anterior suprascapular nerve block, the ASNB, it's often been, well, a reliable choice.
Right, a go-to.
Exactly. And part of the appeal has always been this idea that it manages pain well, but crucially minimizes lung issues, less hemodiaphragmatic paresis or
Well,
HDP.
the phrenic sparing aspect, that's been a big selling point.
But maybe we need to look a bit closer at that assumption. Today we're going to dive deep into an original article just out in Anesthesia and Pain Medicine.
Ah, okay.
It's titled Pathway from Anterior Suprascapular Nerve Block to the Phrenic Nerve, a Cadaveric Dye Study. So let's unpack this.
Yeah, this is important stuff
Okay.
because that perceived safety, especially the phrenic nerve sparing, that's precisely what the study puts under the microscope.
Okay.
The mission here really was to map out where that injectate actually goes when you do a distal ASNB.
Okay.
Does it get near the phrenic nerve?
Because the existing data is a bit messy, right? Contradictory.
Exactly. We've had some cadaver studies, some clinical ones, and they don't quite line up. So there's this gap in, the detailed anatomical picture.
Right.
And understanding that pathway. That could really change how we think about this block in practice.
So how did they tackle it? What was the setup for this anatomical detective work?
Well, it was a cadaveric dye study. Pretty meticulous, actually. They got hold of 12 mech specimens.
From how many cadavers?
6 unembalmed cadavers, aged between 67 and 78, so an older cohort. Keep that in mind.
Unembalmed is key, right? For tissue planes.
Absolutely, a more realistic spread. Then, using ultrasound guidance critical for precision, they injected 5 milliliters of 0.1% methylene blue dye.
And where exactly do they inject? Because location matters hugely here.
Yes, specifically into the proximal part of the suprascapular nerve, infraomohyoid in the posterior triangle, so a defined distal ASNB technique.
Okay, 5 milliliter, distal ASMB, ultrasound guided. Then what?
Then they waited 30 minutes. After that, a blinded dissection. The dissector didn't know, any specifics beyond the protocol.
Blinded. Good. To avoid bias.
Right. They meticulously looked for where that blue dye ended up. And the results, well, they were pretty striking.
Don't leave us hanging. What did they find?
The big one. The phrenic nerve. It was stained blue in 41.7% of the specimens.
Wow, over 40%.
Yep. 5 out of the 12 necks showed phrenic nerve staining. That definitely gives you pause, considering the block's reputation.
Almost half. That is significant. Did they map out how the dye got there? What was the route?
They did, and this is fascinating. The dye primarily traveled dorsally, sort of backwards, along the brachial plexus sheath.
Okay, dorsally. Which part specifically?
So the posterior division of the superior trunk was stained in every single case, 100%.
Every time.
Okay. Also consistently stained were the nerve to subclavias, the dorsal side of the superior trunk, and the C5 and C6 roots themselves.
And what about the lower parts of the plexus?
Interestingly, the inferior trunk was completely clear. No dye there in any specimen.
So it stayed relatively superior, but spread dorsally along C5 and C6. But the phrenic nerve runs more ventrally, doesn't it? How did the dye make that jump?
That's the really interesting bit. After spreading dorsally along the plexus structures near C5 and C6, the dye seemed to sort of wrap around the C5 root.
Wrap around C5.
Yeah. And from there, it stained the proximal part of the phrenic nerve, but on its ventral aspect. Like it took a detour around the root to get to the front.
Okay, that's a specific pathway. Did they quantify the staining intensity?
They did. Qualitatively, they graded it heavy, moderate, mild, or none, so we get a sense it wasn't just a tiny smudge in all cases.
Right. So connecting this back to clinical practice, this really seems to challenge that guaranteed diaphragm-sparing idea, even with just 5 milliliter.
Absolutely. That's the main takeaway. An isolated ASMB, even at this volume, cannot be guaranteed to spare the phrenic nerve. The study suggests it's likely due to the dye traveling along that supple posterior sheath of the plexus.
Like a conduit.
Pretty much. And they also floated the idea of potential phrenicosuprascapular connections, maybe small nerve communications that could offer a shortcut.
Interesting. And what about the other plexus involvement? You mentioned staining beyond just the suprascapular and phrenic nerves.
Yes, that's important too. Remember, 100% staining of the posterior division of the superior trunk, but also the anterior division got stained in 75% of cases.
That'd be 5%.
And the nerve to subclavius and the middle trunk both hit in about 58% of cases.
So you're not just getting an ASNB potentially, you might be getting a partial supraclavicular block too.
Exactly. That's another layer to consider. Potential unintended motor or sensory effects beyond the shoulder joint itself. We need to anticipate that.
Of course, we should touch on limitations. It's a cadaver study.
Right. Always the caveat. Small sample size, only 12 specimens. And dye spread in a cadaver, especially an older one, isn't a perfect match for local anesthetic diffusion in a living patient. Tissue pressures, blood flow, it's different.
True. But still, the anatomical pathway demonstrated is pretty compelling evidence, isn't it?
It is. It provides a very plausible anatomical explanation for the HDP we sometimes see clinically, even when we think we've done a phrenic sparing block.
So summing it all up,
Hmm.
what's the bottom line for the listeners, for us practitioners?
The core message is that this cadaveric study shows a significant, quantifiable risk, over 40% of phrenic nerve involvement with a 5 milliliter distal ASNB. It really challenges the notion that this is inherently a phrenic sparing technique.
So it forces us to reconsider,
Hmm.
which leads to the final thought. Given this evidence, how might this affect your practice? Might you think about adjusting technique, maybe being even more precise with location, or perhaps considering even lower volumes? And where does this push future research? Do we need even more targeted approaches or different blocks altogether for shoulder anesthesia if consistent phrenic sparing is the goal? Lots to think about.